Hi, I want to start today just by really showing my gratitude and appreciation for the award that I received. The Colvin Prize is a phenomenal honor, and I appreciate it. So thank you to BBRF for this opportunity. I'm going to talk today about my work, broadly speaking, in cognition in the context of patients with bipolar disorder. And because this is a relatively short presentation, I'll give a brief overview of where the field stands in this area, and then give an example of some of the work that we're doing in my group. So it was more than a century ago that Emil Kraepelin divided the unitary concept of psychosis into two, where he distinguished patients diagnosed with schizophrenia from those diagnosed with bipolar disorder. And although Kraepelin acknowledged both affective symptom and psychotic symptom overlap between these two disorders, he largely differentiated them based on longitudinal course. So the idea was that an individual diagnosed with schizophrenia would go on after onset to have persistent symptoms, persistent cognitive deficits, and substantial functional disability that remained pretty consistent throughout that person's lifetime. In contrast, he defined bipolar disorder as an episodic illness, and one that was characterized by fluctuations between severe mania, severe depression, but with the expectation that there would be periods of inter-episode recovery, specifically where the affective symptoms and psychotic symptoms would remit, and patients were expected to show a relatively full recovery during that period, both from a cognitive and a functioning standpoint. But when we fast forward 100 years, the reality is shown on the right side of the screen, particularly with regard to functional disability in this disease. This is a snapshot of the World Health Organization top 10 leading causes of disability in the world. And as you see on this list, bipolar disorder ranks number 6, above war, above violence, and above schizophrenia. There have been hundreds of studies that have focused specifically on trying to understand what causes the functional disability in patients with bipolar disorder and other major psychiatric illnesses. And many of those studies show that when we're able to control the mania and to control the depression, and patients achieve that inter-episode affective recovery, that it's the persistent cognitive deficits that remain during that period that are the reason why patients are unable to return to work or function socially in the community. This has made cognition a particularly important target with regard to treatment and understanding how we can promote full recovery in our patients. This is just a snapshot of a PubMed search I did a few days ago in which we're looking at the number of papers published on the topic of cognition and bipolar disorder by year. And this dates back to 1955. I'm going to draw your attention to two dates, particularly of personal relevance to me. The first is 1998, when I started collecting my dissertation data on attention and psychomotor functioning in patients with bipolar disorder. And at that time, there were stunningly few papers previously published on the topic of cognition in this illness. And that year, 34 papers were published. When we fast forward to 2020, just last year, at the peak of this curve, what we see is a very clear exponential growth in the popularity of the topic and the field embracing the importance of cognition in this disease, with a 200-fold increase in the number of publications on this topic since 1998, when I first became interested in this. Despite the growing interest in this area, we still don't know what causes impairment in patients with bipolar disorder. And this is in large part because this disease is exceptionally complex. On the left side of the screen, I'm illustrating some of the bits of information that show the clinical heterogeneity in this illness. There are recognized clinical subtypes based on our DSM diagnoses, bipolar 1 versus bipolar 2, which is largely distinguished based on the severity of mania in these patients. About half of patients with bipolar 1 will experience psychosis as part of their episodes, but the other half will never experience psychosis in their lifetime. When you look at the rate of cycling among patients with bipolar illness, there are patients who will have 4 episodes over their whole life, and there are other patients who will have 4 or more episodes every single year. Much of this clinical heterogeneity is built into the way that we diagnose the disease. We use these symptom checklists that come from the DSM or other statistical manuals for diagnoses. but there are hundreds of different ways that these symptoms can combine to receive a diagnosis of bipolar disorder. And what that means is that one patient with this illness can look extremely different from another patient with this illness and have very few overlapping symptoms. This has been a problem in the research field because what we tend to do from a research perspective is to group all patients as if they're the same because they're all called bipolar patients. And this has really limited our understanding of the pathophysiology of the disease. On top of the clinical heterogeneity, on the right side of the screen, I'm illustrating some of the common comorbidities seen in our patients with bipolar disorder. More than 50% of patients with this diagnosis will experience and receive a diagnosis of substance use disorder at some point in their lifetime. About 50% will carry a comorbid anxiety disorder. Sleep problems are remarkably prevalent in patients even during inter-episode recoveries when affective symptoms are well controlled. Medical comorbidities are extremely high in our patients, and childhood trauma is much more prevalent in bipolar patients than it is in the general population. All of these factors likely influence cognition and community functioning at the individual level, making this an incredibly complex picture for us to try to understand. This heterogeneity maps onto a very clear functional heterogeneity as well. There are many patients with this illness that do very well in their lives. They can be CEOs of companies, doctors, lawyers, or some of the famous people that you see on the screen here. But another substantial proportion of patients experience significant disability, unemployment, homelessness, and yet they carry the same diagnoses as the CEOs and the lawyers. And it's been the focus of my work, particularly over the past decade or so, to try to understand why some patients with this disease thrive in their lifetime and other patients struggle so significantly over time. Because cognition is such a key predictor of functioning in patients, this has been the focus of much of my work. And this is a study I'm showing you that we published about a decade ago, where we did the traditional grouping of all bipolar patients together and compared them with patients diagnosed with schizophrenia and healthy controls. The red line shows a group of remitted patients with bipolar disorder. The green line shows residual phase schizophrenia patients, and the blue line shows healthy individuals. Again, what we've done here is what is traditional in many studies is a case control comparison. And what I want to draw your attention to are two simple facts. The first is that there are qualitatively similar deficits between groups of patients with bipolar disorder and patients with schizophrenia. That is to say that the shapes of those curves are similar. The second key factor, which is shown across many, many studies of this type, is that when you compare patients with bipolar disorder and patients with schizophrenia, patients with schizophrenia will consistently show more severe and profound impairment than patients with bipolar disorder. And so what we see is an impairment in the bipolar group of about 1 standard deviation below average, and a deficit in the schizophrenia group about twice that, about 2 standard deviations below the norm. But importantly, and what I'm going to illustrate for the rest of the talk, is that this approach fails to account for that heterogeneity that I described within the bipolar sample. I'm going to focus on how we parse this heterogeneity to try to learn something new about the disease. So this is a study we published about 7 years ago where we tried to dissect the heterogeneity. We're trying here to acknowledge the fact that not all bipolar patients are the same and that perhaps cognitively they may look different from one another. So here in this study, we took that same cohort of patients with bipolar disorder and we applied an approach called hierarchical clustering analyses. What that basically means is we take the cognitive profile for each patient individually, put it into a statistical analysis, and ask the question, are there homogeneous subgroups that come out that hang together? Are there groups of patients that are more like each other than they are like some other group of patients within the diagnosis of bipolar disorder? And what we found in this study was the answer that yes, indeed, there are subgroups of patients that have some real meaningful differences among them, which I'm going to talk more about in the rest of this talk. But specifically, there are 3 such subtypes based specifically on cognitive profiles. And they're illustrated here in this image. You'll see on the purple line, we refer to this group as cognitively intact. And that's because these individuals, relative to that black dotted line here, are showing no evidence of cognitive impairment on any of the domains seen across the bottom of the screen. Indeed, they actually show superior social cognitive functioning relative to controls. So this subtype of patients with bipolar disorder may well map onto those individuals who do really well in the world. In contrast, there's another subgroup who show these selective impairments on specific domains of cognition, such as processing speed, attention, and social cognition. But some of the cognitive domains are quite intact in these individuals as well. So we've labeled them as selectively impaired. And each of these subtypes are represented by about 30% of the sample. The rest of the sample, the 40%, fall along this blue line. And we've referred to these individuals as globally impaired. And that's because there's a profound impairment of about 2 standard deviations in this subgroup across all of the measures of cognitive functioning, quite different from the profile seen in these other subgroups, and quite similar to the profile seen in a demographically matched group of patients with schizophrenia. So what these data suggest is not just that there's within disorder heterogeneity that can be parsed, but also it suggests there's significant cross-disorder overlap that we fail to see in images such as this. This within disorder heterogeneity and cross-disorder overlap points toward the ability to identify more homogeneous subtypes based on brain function. And with the goal here to identify how this kind of classification might actually be able to tell us something new, not just about cognition, but about bipolar disorder itself. So let's start with what we think we know about the cognitive trajectory in major psychiatric illnesses. This is a hypothetical model in a paper published by Eve Lewandowski about a decade ago. And what this is illustrating is the normal course of cognitive development, which is seen in the dark black line, where individuals, healthy individuals, will show improvement in cognitive performance and cognitive skills over the course of childhood and adolescence until early adulthood, at which the cognitive skills and the cognitive learning will stabilize. In contrast, this dotted black line is illustrating individuals who later develop schizophrenia. And what you see here is that cognitive impairment is present as early as you can measure it, very early in childhood and well before the onset of psychotic symptoms. And indeed, those individuals consistently lag behind their peers all the way up to the point of the first episode of psychosis in late adolescence or early adulthood, at which point you see a small dip in cognitive functioning and then a stabilization over the period after onset of disease. And it is a stable cognitive impairment relative to healthy individuals. These data are among the most consistent bits of evidence that suggest that schizophrenia is a neurodevelopmental disorder, that deficits occur at the level of the brain well before the onset of psychosis and very, very early in life. In contrast, what we think we know about the trajectory in individuals who later develop bipolar disorder is represented on the gray line on this figure. And what we think happens here is that individuals who later develop bipolar disorder show a normal cognitive trajectory up until the point of the onset of disease, which is typically defined as the first episode of mania. And at the time of onset, you see a dip in cognitive functioning and then a bit of recovery and another dip thereafter, a bit of recovery, and a wavy line downward that suggests a neuroprogressive course. This is characterized by cognitive decline and functional disability that's associated specifically with repeated episodes of disease. So note that this isn't a linear decline. It's not about how long a person has been ill. Rather, those arrows represent distinct and discrete episodes. And it is thought that something is happening in the brain with patients with bipolar disorder during these acute episodes that accumulates to cause cognitive decline and functional disability over time. We don't really know what's happening in the brain during these particular episodes that is causing this decline, but it's hypothesized and early data suggest that there are multiple molecular changes that occur during acute episodes. There's downregulation of neuroprotective factors such as BDNF, and there's upregulation of pro-inflammatory cytokines. These molecular changes result at placing the neuron at risk for apoptosis or cell death. And this hypothesis is supported by imaging data that show, in fact, over time, that many patients with bipolar disorder will see a shrinkage or a loss of gray matter in regions of the brain that are most vulnerable, particularly the limbic system as well as the prefrontal cortex. These brain changes are thought to place the person at greater risk for recurrence of disease. And so this is the hypothetical model that we're working from in understanding how this disease may be neuroprogressive. So what do the data tell us? I'm going to be showing you data from about 300 affectively stable patients with bipolar disorder that we've collected over the last 6 or 7 years. When we look at premorbid IQ estimates, that period before the onset of disease, and we compare our whole sample of patients with bipolar disorders with healthy controls, we indeed see no differences. And so this is suggesting that this model here is correct and that there are no premorbid deficits before the onset that are seen in patients with bipolar disorder. However, when we apply the cognitive subtyping approach and we really start to think about and parse that heterogeneity that I've talked about thus far, we see a really different picture. And this approach tells us a very different story. When you look again, just as a reference of the white line being the controls and the black line being all patients with bipolar disorder, when we apply this cognitive subtyping approach, we indeed find that there's a subgroup of patients, a considerable proportion of the patients, about 40%, that do indeed show impairment in premorbid functioning. And this yellow line just indicates a meta-analytic study that looked at the degree of impairment seen premorbidly in individuals who later developed schizophrenia. And you can see that this is incredibly similar. We also see the same pattern that I'm not showing you here when we look at measures of educational attainment. This same subgroup or subtype of patients with bipolar disorder appear to have consistent evidence of premorbid impairment, quite unlike that original model, which assumed that bipolar patients are not impaired during that neurodevelopmental phase. What about when we look at after illness onset, to look at whether or not we are seeing a decline in our patients with bipolar disorder over time? This is just a proxy measure of change, and this is an important caveat of these data. These are cross-sectional, and what we can do using cross-sectional data is different from what we can do using longitudinal studies. But here we were able to use a simple subtraction to compare one's premorbid IQ with one's current IQ and estimate the change that has occurred over the course of the patient's disease. And that simple subtraction measure is shown here when we compare our full cohort of patients with bipolar disorder and a healthy control sample. What we find is very little evidence of change. So what you can see is that the degree of decline over time is very similar in the bipolar patients as it is in patients who are in individuals who are healthy, suggesting that perhaps there isn't cognitive decline in patients with bipolar disorder. These data are consistent with 2 recent meta-analyses that look specifically at longitudinal data. And both of these meta-analyses suggest the same thing, that there is no evidence of cognitive decline in patients with bipolar disorder as a group. Now, the important caveat there is as a group, because none of these studies, including the analyses I'm showing here, have accounted for the heterogeneity within the disease. And of course, when we apply the cognitive subtyping approach, this again tells a different story. So as a reference, again, what we see in controls and in the full bipolar sample is very little evidence of decline and very little difference between these 2 groups. However, when we look at the subtypes that we've derived using cognitive profiles, what we see, again, is a very clear distinction of a subgroup who shows very clear evidence of decline. In fact, changes in cognitive functioning of greater than half a standard deviation between premorbid and current functioning. There's another subgroup shown here that actually shows some improvement in cognition over time. And what you can imagine when we lump them together is that the signal here is completely washed out and lost. And so this approach is telling us something new. It's telling us that some bipolar patients show a declining course and other patients do not. And this is incredibly important to acknowledge and to think about because we need to be able to understand and identify those people who are at greatest risk for decline over time so that we can potentially intervene to stop that from happening. And this is presented in this revised model that we published just earlier this year, where we're trying here to address the heterogeneity within the disorder and to show that there may be subtypes when we think about the trajectory of disease as well. We argue here that there are 3 subtypes within this disorder, and that one of them will show normal premorbid IQ and a resilient course that's characterized by no cognitive decline or no measurable cognitive decline relative to their premorbid period. There's another subgroup that we refer to as a declining course that start off with normal premorbid functioning, but then decline after the onset because of repeated episodes. And then we suggest another subtype, which is more surprising based on original hypothetical models, which is a neurodevelopmental subtype, a group of bipolar patients who actually look neurodevelopmentally much more like patients with schizophrenia and are likely to share risk factors among those patients. Those are individuals who show impairment in premorbid functioning and further decline after the onset of disease. What's really important here is this is a window of opportunity in which we can think about if we can identify the modifiable risk factors for that declining course, then we can intervene early and stop it from happening. I'm going to show you just a couple of things that we identified as being different among these subtypes that may be modifiable risk factors. Due to time, I won't go through everything that we have found. There's a long list of differences between these groups, but there are a few I'm going to highlight here that are particularly important. The first is recurrence rate. And what we can see here is consistent with both of the models I showed you, which is the idea that repeated manias seem to be doing something bad to the brain. So when we look at the number of manic hospitalizations prior to the time we assess these individuals, what we find is that those who are in that resilient or intact subtype have the fewest prior manias. Now, I'll note specifically that these subgroups are matched for illness duration. So these patients have been ill equally as long as those noted in the red and the blue subtype, but they've simply had fewer episodes. So again, this is consistent with the idea that something is happening in the brain during these manic episodes that is creating the likelihood of a cognitively declining course. We don't see depression doing the same thing in this sample. Sleep quality is an incredibly prominent symptom. Sleep quality deficits is a prominent symptom in patients with bipolar disorder, as I mentioned, even during affective remission. And these patients are remitted at the time of our assessment. That black dotted line is the cutoff on this Pittsburgh Sleep Quality Index, and anything above that indicates complaints of sleep quality. So all 3 groups are complaining of problems with sleep, but it's that resilient group that seems to be complaining the least about their sleep problems, and both of those that have indicated and predicted cognitively declining courses that are showing the most problems in sleep. This is important because this is a particularly modifiable clinical factor that is contributing to poor outcomes and should be considered to be a treatment target as we think about optimizing outcomes in our patients. What about biology and biomarkers? This is the last bit of data that I'll show you in context of keeping this talk relatively short. As I noted, inflammation is one of the processes by which we think the brain may be placed at particular risk for decline, particularly as a result of elevated inflammation during these acute episodes. Now, this sample is stable at the time of assessment, and we drew a number of different pro-inflammatory cytokines at that time. Here I'm showing you data just from one, which is tumor necrosis factor alpha, or TNF-alpha. This is one of the key mediators of pro-inflammation and has been studied in multiple bipolar studies showing that it is indeed elevated during mania. And later in the disease, when we do see functional disability, it's more chronically elevated. But in our sample, when we compare our full bipolar sample against healthy controls, we see no evidence of elevation in TNF-alpha or peripheral inflammation in this sample. However, when we apply the cognitive subtyping approach, again, we see really important distinctions between these subtypes. That white dotted line is showing the level of TNF-alpha seen in the healthy control sample. And what you can see is there's a subgroup of patients with bipolar disorder who have lower levels of inflammation relative to controls. But both of those groups that show a potential for declining course are elevated relative to the healthy controls. And again, this is particularly relevant because this has direct implications with regard to targeting treatment. It may be the case that individuals who show elevated inflammation can be targeted with anti-inflammatory medications, with other behavioral strategies that reduce inflammation, but that not all patients are showing this level of inflammation. And when we look at data in this way, we miss this signal completely. This is just a summary of the 3 subtypes that I've outlined based on the data that we have here and some of the things that I've showed that are different by group. What we're really trying to note here is that not all bipolar patients are the same, and outcomes are driven by different things in different subtypes. That also means that treatment needs to be personalized and considered specifically to subtype of disease. So just to conclude, cognitive dysfunction is common and disabling in many patients with bipolar disorder. During remitted phases of the disease, cognitive impairment is one of the strongest predictors of how patients function in the community. This means that treatments need to target this symptom domain specifically, and mood stabilization efforts are often not going to be enough to promote full recovery in patients. It's also noted that addressing heterogeneity is really important because it does tell us something new about this disease. It tells us something new about what causes problems and outcomes in certain patients, and it tells us potentially about treatment targets that may need to be personalized. Indeed, many factors contribute to good and poor outcomes in patients with bipolar disorder, and some of these represent modifiable treatment targets, including things like episode reduction, which is the typical approach used to treating bipolar disorder, but also focusing in on things like sleep improvement and potentially applying other more novel approaches such as anti-inflammatory medications for patients who show elevated inflammation. Overall, the goal of this work is to identify those individuals who are at greatest risk for decline and poor outcome in bipolar disorder. And the goal here, of course, is to try to identify ways in which we can intervene to reduce or even prevent the decline and functional disability from occurring to begin with. Thank you.